Okay, good morning, everyone. It is 9 a.m., week 9, MED240, which is Pharmacology. And before I begin with the review, I'm going to go over the items because that we did in laboratory last week, which is it is part of your final exam, which will be online. If you look all the way at the end, final exam covers everything that we discussed, right? Lectures, homework assignment, but typically the main parts of the PowerPoints that's included, and Dr. Cisco's exams are a little bit, for lack of a better term, they're a little bit more challenging than mine. So when you're looking at the lecture notes, think more basic. I'm not going to ask you something super specific. Think of looking at the drugs in groups, and I'll give more about that in a moment. But let's review, because I don't think I put it up here. Let me look at the announcements. I don't think I put it up. Oh, and real quick, please, I still have several of you missing multiple study questions, and remember, grades are due in like 8 days. So if it's not there, I have no choice but to put zeros. So please get that done. Try to maximize your score on those quizzes. Now, this is demo. Okay, I didn't put it on there. So let's discuss it here so you have a nice video. So what we did last week, we discussed parenteral administration of medications. So what are those? If you look at this right here, these are the roots, and this is a lovely question. So you know what? I'm going to put this, well, it's on video, but let's put this here. Copy image, and I'm going to put it right here on the side. Okay, and I'll make this available for you as well. So let's look at this. There are, we talked about we practiced 3 out of 4 of them. So they spelled intra wrong, but that's okay. Intramuscular. If you could see that the intramuscular has to go straight down, so the needle has to be long, at least 1 inch long, okay? And remember, the length of the needle and the gauge of the needle are 2 different things. Length is, of course, how long it is in inches, and the width, like when you look at the point of the needle, how wide the opening is, that's the gauge. And remember, the higher the number, like gauge 25, 26, 27, that's a very small needle. And if the gauge is smaller, if the gauge number is smaller, it becomes a very, wide opening. So gauge 25, 26, 27, very small. Gauge 17, 15, 13, very large. So just know that the bigger the gauge number, the smaller the lumen or the opening, okay? And intramuscular has to go 90 degrees. Subcutaneous, we only want to get to the fat layer. And if you could see here, they put well, it's colored red, but I guess a maroonish. This will be a vein, right? So in the subcutaneous level, it goes, and the intramuscular level, you could see that you could accidentally, or you could potentially run into a vein. And if that's the case, when you're performing the intramuscular and the subcutaneous, you always have to check if there's blood. So you aspirate a little bit, you pull up on the plunger, and if you don't see any blood here in this little section, let me see if I can make that bigger. This little area right here, remember when we're practicing, if you don't see any blood here, that means you're good to go, then you can push the entire drug through. Intramuscular, 90 degrees. You got to check for blood because you could run into a vein. Subcutaneous, 45 degrees. You got to check for blood because you could potentially run into a vein. Now, of course, intravenous, the down angle is around anywhere from 15 to 25, depending, right? But it is a little bit, you can see how it's more shallow. And the intravenous, we want it to go into vein, okay? And remember, the intravenous, out of all these 4 deliveries of parenteral medication, this is the fastest. So if I push something IV, the effects will be almost instantaneous. Intradermal, last but not least, that you should never do a blood check because it's only in the epidermal layer. And that's what you're doing when you're doing an intradermal. You're trying to create a wheal or a little bump, and of course document that bump. Okay, so this is a lovely picture, and then let's add to these little notes that I'm going to create for you guys. This is a lovely picture because I could ask, where does the needle end up, or where does the medication supposed to end up? It's supposed to end up in these layers. Intramuscular, of course, muscular. Subcutaneous, in the fat or the subcutaneous tissue. Intravenous, you're supposed to be in vein. And intradermal, epidermal, top layer of the dermal at best, and creation of a wheal. Okay, so let's put some extra notes here. I'm going to make them still keep large so you can see it on your screen. So some things that we need to know, that we need to remember, like for example, the intramuscular. What do we need to know? On the technique, we could have Z-track method, and we talked about that, and I'll show a video of it momentarily, right? And that's to prevent epidermal and dermal irritation, and also to keep the drug in the muscle where it belongs. The location of the intramuscular, you can have it in your deltoid. You could have it in your quadriceps or the lateral aspect of your vastus, right, on the side. And of course, most common is your upper outer region of your buttocks or your gluteus maximus. So the muscle in question here is your gluteus maximus upper outer region. Now, what does that mean? And I kind of showed it in lab. But where exactly is the upper outer region or quadrant of your buttocks? If you look at the buttocks, right? Let's look at this. You could separate it into 4 regions like this. Now, your sciatic nerve runs from here, your spinal cord, and goes like this. And that's the reason why we like only the upper outer region, so it'll avoid the sciatic nerve. Your sciatic nerve is a very large nerve and comprises of your S2, S4 nerves, your sacral 2 through sacral 4, so it's large. So the odds of you hitting it could be pretty good if you hit these other quadrants. But if you hit only the upper outer, you should be good. And that's one of the more common places for intramuscular injection. And we talked about in lab that the injections are, you could do vitamins and of course vaccines. Okay. Where's my notes? Now, regarding, why did I have to make this super big? You guys can read it. Now, the next thing is the subcutaneous. So the subcutaneous, we like it because remember what needle we use? We use a tuberculin syringe, right? And those are the orange ones. And also those are the ones for insulin, right? And you'll see on the side, it's marked by 10s, 20, 30, 40, all the way to 100. It's marked in units, okay? What else? Intramuscular, at least 1 inch needle length. Okay. Now the tuberculin syringe, and of course, because we could do insulin and subcutaneous, and the place that we like is the lower quadrants of the abdomen, because there's a lot of fat, because that's where I want the subcutaneous. I want it in the fat. Okay. Intravenous, of course, we didn't practice that. We didn't discuss that, but the big thing about intravenous is it's fast. So if you're going to have side effects, you're going to know in seconds to minutes. Now, what was important about the intradermal? We also use a tuberculin syringe, very small, right? I don't need a big gauge, and that's the one with the orange on it, very small gauge needle. And the thing about intradermal is we use it a lot for skin testing and what's that called? Allergy testing. The areas where you could do it is the volar surface of your arm, which is your forearm, and or the interscapular area of your back. Okay, so right off the bat, wonderful questions that can come just from this picture and just these quick notes. So know the angle, know where the drug is supposed to end up, the methods and locations, and also what kind of material you use, and of course, which one has to check for blood, intramuscular and sub-Q. And of course, intravenous, because I want to make sure I'm in vein. Right? But when you do intravenous, you definitely know it's just like drawing blood. You'll see it, and then oh, we're good, and then you take out the guide needle, and then you push the fluids. Now, parenteral is very different from getting blood. Getting blood, I'm taking something out of the patient, but when you're doing this stuff, you're putting stuff into the patient. So again, all the rules of the 5 R's or the 5 rights, right drug, right patient, right route, and all that apply to this. And remember, check at least 4 times. And where are the 4 times that you check that you have the right drug? When you get the initial order, you check, because when you go to your central supply, that's the first time you check. You check it against the chart. Then when you bring it over to where you prepare it, and you're loading into the needle, check again. That's the second time, right? Then when you bring it over to the patient, right, check it again the 3rd time. When you're ready to rock and roll and administer, check again. Now, it may seem excessive, but I can't tell you how many times in my career that on the 4th check, I found out that I violated one of the 5 rights, or I got the wrong patient. It's the wrong dose, or it's the wrong kind of needle, right? So being that obsessive compulsive is really important. Let me check what else I have here. All right, so that I'll make this available. Let's save as what are we going to call it? Parenteral. First, I got to put the class always, pharmacology. Save it on my desktop, and I'll put it in after the lecture. Okay, so you're responsible for this for your final examination. Now, how's the final exam going to go down? Let's look at the instructions, just so all of us will be on the same page, and whoever is also watching at home. Okay, so it's cumulative. Okay, it goes anything we talked about day 1 to current. But what will the majority of the exam most likely focus on? It'll most likely focus on items from week 5 to week 6. So this will be on the forefront. Anesthetics, analgesics, narcotics, psychiatric and related drugs. That'll be like more than half the exam, right? And of course, CNS disorders. All of that will be on the first half of the exam. So out of 50 items, that would, that would be like 25, 30 questions. And then we're going to start hitting up all the other stuff. Now, this first lecture, Evolution of Medicinal Drugs, Basic Concepts of Pharmacology, expect a couple of questions from there. Dispensing medications, a couple of questions from there. But what is the main purpose of this course? Remember that the two major things that we talked about. Do you know the name of the drug? And do you know what group it belongs to? And if you know what group it belongs to, then you know its mechanism of action. How does the drug work? Because for future reference, knowing how the drug works, you can also know how it messes with you, right? When we were talking about, bioavailability and absorption and all that stuff in the first couple of weeks. But I'm only going to have, some questions on that stuff. But the majority of the questions will be what I just stated, which is the purpose of this class. Do you know the medications? Do you know what they're for? Do you know how they work? And if you can answer those three things for any medication that we talked about in this term, you should ace this exam. And also, this is just the beginning. You will, for those of you moving into nursing, there's a Pharmacology 2, where they take all this information and then they expand everything. You're going to need to know dosage. You're also going to need to actually perform the medication delivery. You're going to actually also have in Pharmacology 2 for future training, you're going to have math and numbers. They're going to give you instructions, and then you have to actually carry out the order. But for now, for Pharmacology 1, for what you guys have, knowing the name, generic, and the proprietary name, which is the brand name, is perfect. And of course, its mechanism of action. How do things go down? And also parenteral medications, because that's what we did last week for our lab. So now you know what we're looking for, right? I'm going to be Thursday, March 11th, and today is what, the 3rd or 4th? Today's the 4th, okay? So this is what I'm going to do in a day. It goes, let's make it, because I know you guys have other exams and other stuff. Let us make it like a, I'll post it like over the weekend instead of like Thursday morning, so that you have a couple of days, okay? So you can mix and match it with your exam. So it's going to be kind of like a take-home exam. And yes, you'll have a lot of time, open book. So if it's open book, you should be able to ace this exam, and you should. So please do so. And all these little study question quizzes, if I give you a 0 for it, that means I don't see your answers. I'm going to go back in there and check, because a whole bunch of you got blanks. But sometimes Moodle doesn't record your score. So I'm going to go in there and see what's going on. And of course, if you have old posts or whatever, please do them, but email me or shoot me a message here in the messaging system that, hey, Dr. Garais, I did something that I previously got a 0 for. Because remember, partial credit is better than no credit. So let's say, for example, I missed discussion 3 and I just took a hit on it, right? Well, go back there. Do it to the best of your ability. And then what I'll do, it goes, I'll at least give you half credit. But remember, half credit is for a good post, at least 200 to 250 words with at least one 7th edition APA formatted citation that's using, a .org, .gov, .edu from a vetted academic professional website. It wasn't this class, but my other class, I still have students doing, picking up like CNBC and Wikipedia and Medscape. those aren't really academic. So find true academic sources, because in the future you're going to have professors, if you don't have a proper academic source, they're just going to give you a zero. And because if it's not from an academic source, what are you doing? You're proliferating bad science, which is essentially, if you guys watch the news, that's all they do all day. All day. He goes, you want to be entertained? Watch the general news. And what I love doing is I watch two news, more than one news station at a time, to see how they contradict each other. It's really interesting to watch. So let's now review what are some kind of questions that'll come out, and what do I mean by knowing your category, and knowing your what group things belong into. Like, so for example, I could, because I could be a real stinker and ask, like, is ampicillin broad spectrum, narrow spectrum, both, or neither? I'm not going to do that. I'm gonna more likely ask a question like, ampicillin can act against both gram-positive and gram-negative bacteria. Is that considered A, broad spectrum, B, narrow spectrum, C, both, D, neither? And if it could hit multiple types of bacteria, you know that's what? It's definitely, oh, that's broad spectrum, okay? Another broad spectrum question that I could ask is, remember I talked about prophylaxis, especially with surgeries? I don't know what you're going to get hit with after the surgery or during the surgery. So I want to hit a broad spectrum. So a lot of prophylactic, and also, let's say you had an infection, right? And the culture and sensitivity won't come back in anywhere from 5 to 9 days. So I have to do some empiric therapy. So I don't know what you have. So the doctor is going to give you, and sometimes they call it shotgun therapy, where, a shotgun, it kind of sprays in a general direction. And that's what broad spectrum is. We talked about really big on inhibit the cell wall. And the penicillin family, because I've mentioned it several times. So that's the one thing you got to, and this is a lovely slide right here. Because can I do something like quinolones? Do they A, interfere with DNA, B, inhibit the cell wall, C, disrupt cell membrane, D, prevent folic acid synthesis? So a slide like this is beautiful. It's right here, right? This is exactly what we're talking about. So you see anything MOA, it should be. Now, remember I mentioned antibiotic side effects? Did I ever mention really, really specific? No, it's more of generalities. For example, side effects of antibiotics, most common, right? So I don't have to know the exceptions or things like that. The side effects is, one, we always talk about how it's going to mess with your gastrointestinal. And two, we always talked about superinfection. If you misuse your pills or your antibiotics, what are you going to get? You're going to get an infection that's a lot stronger than the original one, because the bacteria that lives after your first round of antibiotics, they're stronger and they're already used to the medication. And remember, I gave the example of how tetracyclines nowadays are they're like 35% efficacious, meaning to say is I give tetracycline 35 times out of 100, right? It'll work. The other 65 times, most likely it won't work. But we still use it because it's still a frontline drug. So something like this, know the mechanism of actions and what they match to. Another thing is that, remember during my lectures, I mentioned most common, or what I see a lot when I used to practice, right? So this Bactrim, I mentioned this, cotrimoxazole, right? They're crazy, very common. So that's the one you memorize for sulfonamides. You don't have to go and then try to remember all the side effects and all the different kinds of sulfonamides. That's for future training. That's for pharmacology too. But just have a classic example and know that, remember, if we go back to our MOA, sulfonamides, their function is where it is, prevent folic acid synthesis. Right? And you saw that kind of thing in the midterm. So when you go over your bacterial stuff, your antibacterial stuff, antiviral stuff, the stuff that we also covered for midterm, that's the kind of questions I would ask. And remember, 50 items, multiple choice. Know the difference between an antifungal and antiviral, right? And remember, the most common, right? And the most common for antiviral, it'll have vir in it somewhere, all right? And also know your HIV meds, because it was an actual, it was actual separate handout. Now, what do I like about anesthesias, analgesics, and narcotics? Right? Again, mechanism of action. What does it do? It either mimics or blocks neurotransmitters. And we know what neurotransmitters do. They propagate the signal. Electrical signal goes through this, the neuron or the nerve cell, and then at the terminal bud, they release chemicals called neurotransmitters. And if we mess with these neurotransmitters, we can do a whole bunch of things with anti-epileptic medication, antidepressant medication, antipsychotic medication. So there's a broad spectrum, and this is the main mechanism of action on how a lot of these psychiatric and neurologic medications work. And knowing the divisions of this, central, and nice to know, might have a question out there. And actually, you should know this. This is from your Anatomy Physiology 1 and 2. This thing is big right here. When we talk about neurotransmitters, I want you to know GABA. Gamma aminobutyric acid, of course, and GABA is always think blocking, okay? Always think that it's like gabapentin for anti-seizure, antidepressant, antipsychotic medication. That's the all of the above example that I gave in that lecture. Know that it has what? Blocking or negative effects. And then you have acetylcholine. I want you to think, oh, smooth muscle, cardiac muscle, okay? And because if you look here, the acetylcholine affects both the sympathetic and parasympathetic nervous system, right? And we already know norepinephrine, dopamine, and epinephrine affect the sympathetic nervous system. Remember fight or flight? What do you think cocaine mimics? And crack cocaine and heroin, it mimics all of this. So that's a kind of sympathetic, and we know the sympathetic nervous system is fight or flight. The parasympathetic nervous system is the exact opposite within the autonomic nervous system. Okay, so knowing what dopamine, epinephrine, serotonin, what they're all related to is very, very good question that'll come out. Now, types of receptors, right? Maybe it's nice to know. In pathology, you'll definitely need to know, and especially when you eventually go to your med surge, when they start talking about the specifics of blood pressure medication. But yeah, this is nice to know, right? Side effects of anticholinergic. Dr. Cisco has it in red, and has it in red for a reason, because anticholinergics, think of what? It's going to mess with my GI, and it's going to mess with my cardiac. So, and just know that it decreased GI motility, decreased sweating, decreased urination. Think of what? If it's an anticholinergic, it's going to block sympathetic, and that. And it has those effects, if you can see here. Anesthesia, what do you need to know about anesthesia? If it's local, it's relatively safe. But if it's gas or general, it's kind of dangerous, okay? And that's why we have an entire department of anesthesiology. They're the ones who safeguard your lives. Now, what's common? You see this in red: narcotics, benzos, right? Remember we talked about Valium, benzodiazepine, all the PAMs. That's for anti-anxiety, right? And um, what else do you need to know? Dantrolene is nice to know. Characteristics of inhalants. Uh, yeah, this is nice because now you understand why there has to be an anesthesiologist on every surgery, because those inhalant and very dangerous anesthetics, they're going to drop your blood pressure, drop your renal function. They're going to do everything. And again, since it's also partial narcotic, nausea and vomiting are very, very common with our narcotics. Nitrous, very, very, very common, right? And what's another good one? Some of them are injectable, but again, you don't need to memorize the whole list. But what do you need to know? Benzos. They're very, very common. Diazepam, lorazepam, and midazolam. Valium, Ativan, and Versed. This definitely has to come out because this is, especially Valium and Ativan, they are the most abused. A lot of doctors give them for everything from sleep to anxiety to, oh, I have a really important business meeting tomorrow. There's a lot of abuse potential here for benzos. And propofol, remember we talked about how that's used typically for surgery, but apparently Michael Jackson's physician thought it would be good for daily use, which is interesting, right? So benzos, that's very, very common. Now I could ask a question between agonist and antagonist. And remember, what's an antagonist? It will anti or reverse the narcotic effects. And the most common is right here, naloxone, also known as Narcan. Very, very potent um, um, anti-narcotic. But there are certain narcotics that are just don't respond well to it, and one of those is phencyclidine, also known as PCP, also known as angel dust. But for like crack cocaine, ooh, naloxone is really good. It like turns it very, very quickly. Neuromuscular blocking agents, nice to know. Um, Succinylcholine, yeah, good to know, right? Local anesthetics. I want you to think anything with like a cane, right? Bupivacaine, levobupivacaine, lidocaine, xylocaine, benzocaine. You don't have to know ester versus amide, but know that a lot of the local anesthesia, like if I'm doing a heart block or a foot block, I'm only doing a couple stitches in your hand or in your fingers. I'm going to use lidocaine, xylocaine, lidocaine epi. So anything with a cane, I want you to think, oh, that's local, right? Except, of course, cocaine, right? And guess what these things are? They're similar derivatives, but in a localized, it'll only deal with um, um, anesthesia in a local part of your body, like just your hand or just your arm. When we don't want to do general anesthesia, which will be your whole entire body and focusing on your central nervous system. And that's when we need an anesthesiologist, and that's when it gets a little bit, gets a little bit dangerous. Most common for analgesia, think NSAIDs, nonsteroidal anti-inflammatory drugs. They are way better than narcotics because there's no abuse potential. Many of them are over the counter, and they have minimal side effects. But narcotics have a lot of problems, and the primary one is potential addiction, especially for your category or class 2. But analgesia, know this term, analgesia and sedation, right? When we want to sedate the patient, we want to decrease their anxiety, make them sleepy, make them calm. But analgesia, we want the pain to go away, or in many cases, especially with the NSAIDs, just enough to cut the edge off of it. If any of you ever had pain states, and you take something like naproxen, which is a quite potent NSAID. It's last time I had a really bad gout attack, it still hurt, but it didn't hurt to the point where I'm crying. Like, it hurt to the point where I can tolerate it and then go to sleep. Okay. But we like NSAIDs. Okay. We don't like combining it like with codeine, like Tylenol 3. Tylenol 3 is Tylenol, acetaminophen with codeine, and the number that is after, like Tylenol 3, it talks about the potency. Tylenol 3 is less potent than 5, less potent than 6. That kind of thing. Ooh, and what are the heavy hitters that are very common, and you've heard of them? Of course, any of the contins: OxyContin, oxycodone, codeine, hydromorphone, Dilaudid, Demerol, right? All of these, right? But OxyContin, Dilaudid, Demerol, they're very, very, very common. But I always dispense with caution. And in the state of New York, you're not allowed to give more than 3 or 4 days worth of that stuff. And if the patient still has a pain state after that, the patient has to come back in. Unlike Virginia, who gave my wife 30 pills the other day, I have her on cut dose of oxycodone. She only had to use it, twice in the last week? So why are you giving, like, they want us to start a drug business? I don't know what they want us to do. But I find that very, very dangerous. I hope they change those rules here in the DMV, because that is kind of dangerous. And it might be annoying to the patient, but if your patient still has significant pain states that require codeine for more than 2 or 3 days, then the problem that we're trying to address isn't solved. So the patient should go back to their physician. Okay. And of course, all of this stuff, all the medications, the best rule is no alcohol due to potential disulfiram effects or potential potentiation or synergy with the drug. It might make the drug worse. No alcohol, and of course, always follow the label. Okay. Oh, and I could do that too. I could put a label out and say, hey, it goes, what's important about this, that, and the other thing. Or just like the midterm, can you read the label? Okay, I could put that out as well. Vicodin, these are some serious stuff. Percocet, Percodan, they're all oxycodone derivatives. They're just, I don't like them. And also, there are a lot of side effects. And the most common side effects for narcotics when they come down is vomiting, nausea and vomiting, extreme nausea and vomiting. It's just, me personally, it's not worth it. What I like also doing is sometimes I do every other combo with, like, I have the patient take ibuprofen and then take cut dose of oxy, and then ibuprofen, oxy as needed. But I make it like Q6 or every 6 hours. You could make it as short as 4, which is crazy. But and I consider myself rather aggressive in my management. Q6 is already, it's already something to look after. Now, migraines. What's the big thing about migraines is that currently, right now, we're not quite, according to my mother, she's a neuropsychiatrist, there's no one agrees on the mechanism of action of how migraines work. But me, professionally and personally, I believe that it is an overstimulation of the brain, just like seizures are overstimulation of the brain. That's why the patient can't handle bright lights and sounds, and the pain is very, very, very debilitating. And so there's a lot of factors here, right? And you could see they're all over the place. But the biggest factor that that we're trying to deal with is the vasodilatation that always occurs with migraine. Meaning to say is your brain will be flooded with a lot of oxygen and a lot of stimulation. So the one thing that we try to do is not only, of course, take away any sensory, right? You know, the patient has to be in a quiet room, dark room. And I was talking to some migraine patients last night, some students, they were like, Dr. Garais, they were like, sometimes when it gets really bad, even doing that and with the meds, it doesn't work. I just have to suffer through it. I'm like, wow. So you can see how debilitating that could be. But the focus is on if the problem is too much vasodilatation on a migraine, so what will we most likely give? Vasoconstriction. And that's why, a lot of them drink a lot of coffee and have a lot of caffeine, because we know that caffeine increases your blood pressure through vasoconstriction. So there's a lot of anecdotal evidence, meaning to say is there are a lot of patients who swear by it. They're like, oh, if I take my caffeine pills or if I take a Starbucks, it goes away, that kind of thing, right? So remember, initial treatment is what? Get rid of the sensory attack. If you know what is a causative factor like stress or atmospheric changes or environmental irritants, meaning it's too loud or too bright, then get away from what irritates you. So that's the first one. And then you could have prophylactic or abortive. Prophylactic is I'm doing prevention, but abortive is I'm taking the drug as needed, or PRN, when they go through. So doesn't this look like a both? Doesn't this look like a beautiful? Is it A? Is it B? Both? Neither, right? Or I could give you the situation. Is it A, B, both, and neither? And do you have to memorize this? No. I just want you to know there's a group. It's called prophylactic, and there's another group, abortive, right? Um, and serotonin, right? Anything triptan, okay? So triptan, sumatriptan, Imitrex, and that's really, Dr. Cisco put it in red because there's commercials for Imitrex all over the place, and that's triptans. So do you have to memorize all these specific drugs? No. You have to know that the mechanism of action of an abortive therapy, big time, is what? Serotonin. Serotonin receptor agonist. And remember what we talked about before? Serotonin is big on dreams. And what happens when you're dreaming? You're in happy land. Your brain is what? Organized and quiet, relatively, right? And that's what you want. That's why a nice little hint before taking your exam, make sure you're well rested, okay? And a nice B is ergotamine, and ergotamine works just like caffeine. It promotes vasoconstriction. What else looks good? Caffeine, right? Make them drink coffee or Red Bull. Tramadol really common, but I don't find tramadol powerful. I don't like it. And of course, right, your NSAIDs, acetaminophen, right? And if you see like Excedrin migraine or Tylenol migraine, it has some sort of caffeine in there. Okay. So when you're looking at the PowerPoints, look at it in its broad view, instead of right now for the exam memorizing specific drugs. Know your most common and what category and what mechanism of action it belongs to. And let's see, let's look at the psych drugs. Oops, that's a quiz. My bad. CNS, psych drugs. What looks good for psych? Okay. Know that many of the antidepressants take weeks to a month. Know your 4 categories and how they work. So SSRIs and SNRIs, what do? They block reuptake and keep serotonin in the synaptic gap longer, right? How do tricyclic antidepressant works? How do monoamine oxidase inhibitor, also known as MAO inhibitors, work? Okay, right. So do they work? Do they mess with serotonin, or do they mess with norepinephrine? Okay, and look, beautiful. This is another mechanism of action. Doesn't this look like a beautiful set of questions? SSRI goes, what does it mess with? Serotonin, norepinephrine, both, neither. SNRI, is it serotonin, epinephrine, both, neither. TCA, you could figure out all possible ways. And the big thing is what? It could take up to a month to work, which is hard on compliance, because if the patient doesn't see results, they tend not to take the medication. No, the most common, Lexapro, Prozac, Paxil, Zoloft. No, the generic, right, which is paroxetine, right, the lowercase letters, and the proprietary drug, or the proprietary name, which is in parentheses and have the capital, because this is, you'll see these drugs all over the place. They're, my wife's data, she deals with hundreds of patients a day. Almost a third of her patients are on these meds, and something like 250 million people, some ridiculous number. Last time I went to the American Psychiatric Association conference, pre-COVID, I went like that January, right before March, and the numbers of people on these meds were staggering. And then the whole entire time there were a lot of lectures on how we can like start to minimize that, because it's a little much. And there's people taking antidepressants because they couldn't find a good bid on whatever they were looking for on eBay, like for like silly things. Also note that things like carbamazepine, which is Tegretol, divalproex, Depakote. Remember we talked about how some drugs are also used as anticonvulsants, like these two drugs, but they're also used for antidepressants. No lithium, big time. Lithium is bipolar, but the thing about lithium is that it crosses the blood-brain barrier very quickly, and the therapeutic range is very, very small. Meaning to say is, in either direction, under 0.8 or greater than 1.2 mecs per liter, you're going to have toxic effects, or it won't work at all. If it won't work at all, if it's under 0.8, and you're going to have toxic side effects, as in serious CNS problems, central nervous system problems. I've seen some doctors push up to 1.5, and then they call us, and then they call internal medicine, like, hey, what's wrong? And because all of these neurotransmitters, if you recall your anatomy physiology, right up here, right above the corpus callosum, here in your brain, is your limbic system. So we already know that chemicals control your mood, right? And that's why we have a department of psychiatry. But remember my lecture, you always have to have psychotherapy, meaning you have to speak to your patient to get to the root of why are they depressed? Why do they have feelings of psychosis? Why are they paranoid? Because you got to find their story. And a psychiatric story, my goodness, it's very convoluted. It's very hard to understand. You don't know if they're lying, or it's very, very difficult. Most of my psychiatric interviews will be like anywhere from 45 minutes to an hour and a half, just to get the subjective part, because they half the time you don't know if they're lying or they're making it up, or if they're psychotic, or they're not in this reality. Because if they're not in this reality, how valuable is what's coming out of their mouth? It won't be, because they could have hallucinations, and really bizarre behavior. During last night's laboratory, we talked about, if you guys recall, I mentioned something called precox, or precognitive. That's when, have you ever met somebody they're saying all the right things. They look perfectly fine, but the way they talk to you or just the way they act with you, you find there's something off about them. Well, they could be psychotic, they could be on meds, and a whole bunch of things, right? What's some good ones? Of course, we talked about Zyprexa, Seroquel, Risperdal, and Geodone. And you see all of them have what? Zapine, 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 or Zol, 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 right? But Zyprexa, Seroquel, Risperdal, and Geodone, top four, right? So if I mention any of those and I ask, what are they? And you'll tell me, I won't even ask if they're atypical antipsychotic medication. You'll tell me it's an antipsychotic medication. Abilify is nice. It's relatively new. They like it, but me, I like old school. Zyprexa. Ooh, doesn't it look like a beautiful both A and B? Dopamine and serotonin. Looks nice. Risperdal, Risperdone. Remember, I mentioned it is the first drug approved for autism. But remember what I stated. It's not really to treat the autism. It's really to treat the effects or the behavior, the bizarre behavior that many autism patients may have. Because remember, an autistic patient, they have a sensory and a processing problem. So what you and I see and hear and process during the course of the day may not bother you, but for an autistic patient, it may bother them severely. So and may skew their reality. So we, especially when they throw tantrums, we like giving them Risperdal. So that's another thing. If something is like drug of choice or DOC for a certain thing, like lithium, drug of choice, or a mainstay drug for bipolar, that's something that you should know. Risperdal, autism, something you should know. Anti-anxiety, remember the thing that we always talked about, Valium and Ativan and Xanax, right? Alprazolam, Valium, diazepam, Ativan, and lorazepam. There's so many people on it. There's just way too many people on it. And that's benzos. And even though they're classified as a category 4 drug, that in theory it's not supposed to be physically addicting, it's mentally addicting. I had a lot of patients who are mentally and socially addicted to Xanax and Valium. I have patients who can't sleep, who will not sleep without taking Valium. And even when I do placebos, they still can't go to sleep, but they need it. Buspar, nice to know. But remember I mentioned Buspar for like diet control and stuff like that. And the irony is, of course, you take it with food. Sleep disorders, nice to know. Not a lot of people have narcolepsy. Let's think more common, which is antidepressants, antipsychotics, right? Anti-anxiety. Now, remember the other thing that I mentioned that's really common? If my patient has a sleeping problem and I don't want to give them lorazepam or diazepam, right? I don't want to give them a benzodiazepine, right? I can give them an antihistamine, because the major side effect of antihistamine, like Benadryl, is you get sleepy, right? So if my patient has some trouble sleeping, you give them a cut dose of Benadryl before they go to sleep, when around the time they need to go to sleep. Hypnotics, nice to know. Well, Ambien for sleep, right? But it does the same horrible things. And also Zolpidem. I've had several patients who are they're not physically addicted to Zolpidem, but they're definitely emotionally connected to it. Alcoholism, the big thing you have to know about alcoholism is the drug disulfiram, and drugs that mess with alcohol has a bad side effect with. Remember, that's disulfiram effects. It causes severe GI disturbance and vomiting, and that's why we like it for alcoholism, because then it turns the patient off to drinking. But you'd be amazed. Alcoholics are and any drug addict, that it's like taking away water or food from a human being. And the proprietary name or the brand name for disulfiram is Antabuse. Oh, and even they get vomit. This is another quick nice thing. Anything that has even little bit of alcohol in it, right? The patient has to be aware of, because it'll just make them start vomiting. Their head hurts. They get like bright red. Some of them even have dyspnea, right? Topamax, I don't have much experience with, but Antabuse, very common. Okay, let's let us wrap this up. So, CNS drugs, psychiatric drugs, anesthetics and analgesics and narcotics, that'll be like what, 30 questions out of 50. What's the rest, right? Of course, I'm gonna have to ask about HIV, a couple antifungals, the more common ones, but the HIV antivirals, I'm definitely gonna ask about that. And the antibiotics, I'm definitely gonna ask that again, but again, based on drugs of choice and what's most common. 50 items, multiple choice. I'll probably put it up by like Saturday or Sunday. If you don't see it by like Saturday night, shoot me an email, give me a call, and I will put it not here. So when you look at this thing and click on this thing, this is Dr. Sisko's exam. I left it up here because this is a nice practice exam. So if you want to have a really hard exam to see if you can do this one, yeah, you could try this one out. Mine is, like I said, mine is going to be my version of it. And it's going to look a lot like your midterm. Remember, 50 items. And where will I place it? I'll place it here, right after I put the video here for week 9, and it's due by March 11. What time March 11 did I say? March 11 via email. So you email me the answers, just the answers. Now I'm on video. Can I repeat it? Just the answers. No pictures of handwritten things, just an email. And the inside the email has your name, of course. It says MED240, final written exam. And then you'll have 1 through 50 and a whole bunch of letters, right, as your answers, okay? And it'll be an announcement. It'll be during week 9. And you have until Thursday, March 11, 2021, midnight to post it, okay? Now, if you, like, let's say you did it on Monday and you sent it to me and you didn't get anything back, call me or email me again, because just like the midterm, I will confirm, I will send you something back via email. Got it, confirmed, because many times I can't open the file or something got corrupted or something got messed up, and then I email the student back and they don't email me back. And remember, I've got to post grades by like that Saturday by 12 noon. So if you don't answer me back immediately, and also if you don't do, any missing assignments or anything, then I have no choice. I have to put zeros down, and and that's not a good thing, because it negates all the work that you've done. Okay, let me look at some questions here in the chat. Right, and well, I answered that is, now if you can't get into this final exam, let me click on it here, right? Oh, it's closed. Oh, let me open it. I'll open it. Let me write that down. Open exam. Open the exam. Another thing that I could also do, it'll take me a minute, I could also put a practice exam. I'll put another practice exam as well. The more the merrier. All right. So thank you for informing that. I can open that after class. Now it's at this point of the show, I'm going to stop the recording, and then I'm going to take any questions. And if you don't have any questions,